Welcome to another episode from the Veterinary Medicine Digest. Today, we're diving deep into a topic that many pet owners and veterinary professionals encounter: diabetes mellitus in our beloved dogs and cats. It's a common condition, but managing it can often feel complicated and overwhelming. But fear not. The goal of today's episode is to demystify this disease, exploring everything from its fundamental causes and diagnosis to the intricacies of treatment, monitoring, and even the management of serious complications. We want to equip you with a comprehensive understanding built on current scientific evidence and sound clinical judgment, because success in managing diabetes truly requires a committed partnership between the veterinarian and the client. So, let's start with the basics. What exactly is diabetes mellitus? At its core, diabetes mellitus is a syndrome defined by prolonged high blood sugar or hyperglycemia. This happens because of a problem with a very important hormone called insulin. Either the pancreas isn't producing enough insulin, the body's tissues aren't responding to it properly, or some combination of both is at play. Regardless of the specific cause, the result is a cascade of classic clinical signs that often bring pets into the clinic: excessive urination, known as polyuria, excessive thirst or polydipsia, and increased appetite, called polyphagia, and despite eating more, progressive weight loss. These signs appear because when blood glucose gets too high, it spills over into the urine, a condition called glucosuria. This typically happens when blood glucose exceeds about 200 milligrams per deciliter in dogs and somewhere between 250 to 300 in cats. The glucose in the urine pulls water with it, leading to that excessive urination and the compensatory thirst. The weight loss occurs because without insulin, the body's cells can't use glucose for energy, so they start breaking down fat and protein stores instead. This metabolic shift also leads to high levels of fats, like cholesterol and triglycerides, in the blood. If left untreated, this process can escalate, leading to the production of ketones and a life-threatening state called diabetic ketoacidosis. But it's crucial to understand that diabetes is not a single, uniform disease. It's a heterogeneous group of diseases with multiple causes, and the underlying mechanisms can be quite different, especially when we compare our canine and feline companions. This is where the story gets really interesting, because understanding these differences is vital for tailoring the right treatment to the right patient. The canine diabetes story, a tale of insulin deficiency. Let's first turn our attention to dogs. In almost all cases, canine diabetes is a disease of permanent insulin deficiency. The insulin-producing cells in the pancreas, called beta cells, are progressively lost or destroyed. This makes canine diabetes phenotypically similar to type 1 diabetes in people, which is often diagnosed in childhood and characterized by an autoimmune attack on the pancreas. For a long time, autoimmunity was considered a primary suspect in dogs as well. The idea was that the dog's own immune system was mistakenly destroying its beta cells. And indeed, some studies have found autoantibodies, antibodies against the body's own proteins like insulin or proinsulin, in some diabetic dogs. Furthermore, genetic studies have linked canine diabetes to the dog leukocyte antigen genes, which are part of the major histocompatibility complex that governs the immune system. This certainly points to a role for the adaptive immune system in the disease, at least in some breeds. However, the plot thickens. Many diabetic dogs, sometimes more than half in certain studies, show no serological evidence of autoimmunity. The classic microscopic finding in human type 1 diabetes is an infiltration of lymphocytes into the pancreatic islets, a feature known as insulitis, but this is only rarely reported in dogs. This has led to a shift in focus. While the immune system is likely involved, many experts now believe that autoimmunity is a less important aspect of the disease than previously thought, with more attention now being paid to the overall health and robustness of the beta cells themselves. The thinking is now geared more towards how susceptible these cells are to various stressors that can lead to their demise. Genetics undeniably plays a huge role. We consistently see certain breeds that are highly predisposed to diabetes, such as the Samoyed, Tibetan Terrier, and miniature poodle, while others like the Boxer and Golden Retriever seem relatively protected. This strongly suggests that there are breed-specific genetic variations that either increase risk or offer protection. These genetic factors might not only directly affect beta cell health, but could also predispose a dog to other conditions that indirectly lead to diabetes, like pancreatitis or hyperlipidemia. Another major contributor to canine diabetes, particularly in intact female dogs, is insulin resistance caused by hormones. During diestrus, the phase of the reproductive cycle following heat, high levels of progesterone can induce the mammary glands to overproduce growth hormone. Both progesterone and growth hormone antagonize insulin's action, creating a state of insulin resistance that can be severe enough to cause temporary or even permanent diabetes. This is why spaying an intact diabetic dog is so crucial. It can sometimes even lead to remission of the diabetes. Concurrent diseases are also a major factor. Hyperadrenocorticism, or Cushing's disease, causes high levels of cortisol, which induces insulin resistance. In fact, about 23% of diabetic dogs have been found to have concurrent Cushing's disease. Sometimes it's difficult to know which disease came first, but it highlights the complex interplay of different hormonal systems. Finally, we cannot ignore the role of the exocrine pancreas, the part of the organ that produces digestive enzymes. Pancreatitis, or inflammation of the pancreas, is estimated to be present in 28 to 40% of diabetic dogs. The relationship is complex, and we'll explore it in more detail later, but it's thought that the inflammation can cause bystander damage to the nearby beta cells, leading to their destruction and subsequent insulin deficiency. The feline diabetes story, a tale of insulin resistance. Now let's switch gears and talk about cats. The story of feline diabetes is quite different and, in many ways, more closely resembles type 2 diabetes in people. Unlike the absolute insulin deficiency we see in dogs, feline diabetes is typically characterized by two key problems: insulin resistance, where the body's tissues don't respond effectively to insulin, and impaired insulin secretion from the beta cells. The single biggest risk factor for this insulin resistance in cats is obesity. A sedentary indoor lifestyle and physical inactivity also contribute significantly. Obese cats often exist in a pre-diabetic, glucose-intolerant state for some time before they develop overt diabetes. Their pancreas tries to compensate for the insulin resistance by pumping out more and more insulin, but eventually, the beta cells become exhausted and can no longer keep up with the demand. This leads to a crucial concept in feline diabetes, known as glucose toxicity. Persistent hyperglycemia itself is toxic to the pancreatic beta cells. It causes dysfunction and eventually leads to their death through a process called apoptosis, or programmed cell death. This pathophysiology is what makes one of the most remarkable features of feline diabetes possible: diabetic remission. Because many cats still have some functioning beta cells at the time of diagnosis, albeit impaired ones, there's a chance for them to recover if the glucose toxicity is reversed. With aggressive treatment, typically a combination of insulin and a very low-carbohydrate diet, the blood glucose can be brought under control, the stress on the pancreas is relieved, and the beta cells can regain their function, sometimes to the point where insulin injections are no longer needed. Remission rates can be quite variable, reported anywhere from 15 to 100% in different studies, but it is always a reasonable goal for a newly diagnosed diabetic cat. Like dogs, cats can also have their diabetes triggered or complicated by pancreatitis. In fact, post-mortem studies have shown that the prevalence of pancreatic inflammation may be even higher in diabetic cats than in the general feline population. Given that inflammation is a known cause of insulin resistance, it's easy to see how pancreatitis could be a direct contributor to the development of feline diabetes. Other causes of insulin resistance in cats include diseases like acromegaly, which involves excess growth hormone, and hyperadrenocorticism, though these are less common. The road to diagnosis and the art of treatment. So, how do we diagnose diabetes? The process begins when a pet presents with those classic signs we mentioned earlier: drinking a lot, urinating a lot, eating a lot, and losing weight. The diagnosis is confirmed by finding persistent hyperglycemia and glucosuria. It's the word persistent that's key here, especially in cats. Cats are masters of stress hyperglycemia. A single high blood glucose reading in the clinic can be misleading. To differentiate this from true diabetes, a serum fructosamine test is often necessary. Fructosamine is a protein that gets glucose bound to it over time, so its level reflects the average blood glucose over the previous 1 to 2 weeks, giving a much better picture of the long-term situation. Once a diagnosis is made, the initial evaluation should be thorough. We need to assess the pet's overall health, look for complications like cataracts in dogs or peripheral neuropathy in cats, and screen for concurrent problems that can interfere with treatment, such as urinary tract infections, pancreatitis, or other endocrinopathies. A urine culture is always recommended because the glucose-rich urine is a perfect breeding ground for bacteria, and infections are common. Now, on to treatment. The cornerstone of therapy for clinical diabetes in both dogs and cats is insulin, often combined with dietary modification. The goals of treatment are simple in principle but can be challenging in practice. We want to control the clinical signs of diabetes while, most importantly, avoiding clinically significant hypoglycemia or low blood sugar. We're not necessarily aiming for perfectly normal blood glucose levels all day long. The practical goal is to keep the blood glucose below the renal threshold for most of the day, which stops the glucosuria and resolves the excessive thirst and urination. For dogs, treatment always requires insulin injections. A top choice for many veterinarians is AU 40 porcine lente insulin, which has a brand name of Vetsulin. This is an intermediate-acting insulin, and its duration of action is close to 12 hours in most dogs, making it suitable for twice-daily injections. The recommended starting dose is typically around 0.25 units per kilogram, given every 12 hours with a meal. Dietary management in dogs focuses on consistency. They should be fed equal-sized meals twice a day, at the time of each insulin injection. The ideal diet will help optimize their body weight and minimize the spike in blood glucose that happens after meal. Diets with increased soluble and insoluble fiber are often recommended because they can help slow glucose absorption and improve glycemic control. For cats, as we've discussed, the goal of remission is on the table. The approach is often more intensive. The insulin of choice is frequently a long-acting one, like Glargine, which is known as Lantus or protamine zinc insulin, also called PZI or Prozinc. These insulins provide a steadier, longer-lasting effect that is very effective in cats. The typical starting dose is low, usually 1 to 2 units per cat, twice a day. The dietary component for cats is critical and very different from dogs. Diabetic cats should be fed a high-protein, low-carbohydrate diet. Canned foods are generally preferred over dry foods because they naturally have lower carbohydrate levels, help with portion control, and provide extra water intake. This dietary strategy, combined with an effective long-acting insulin, is what gives cats the best chance of achieving remission. There are several other types of insulin available, including NPH, which is an intermediate-acting insulin used in some dogs but generally not cats due to its short duration of effect, and Detamir, another long-acting insulin that is very potent in dogs and must be used with caution. It's worth noting that while compounded insulins are available, their use is generally not recommended due to concerns about consistency, sterility, and efficacy. While insulin is the mainstay, there are a few non-insulin oral medications. Sulfonylureas like glipizide can be used in some cats to stimulate insulin secretion, but they are generally reserved for situations where an owner refuses insulin therapy, as there are concerns about their long-term effects on the pancreas. Alpha-glucosidase inhibitors like acarbose can be used in both dogs and cats alongside insulin to help reduce postprandial hyperglycemia by inhibiting glucose absorption from the gut. The critical role of monitoring. Managing diabetes is a dynamic process. It requires frequent reassessment and modification of the treatment plan. This is where monitoring comes in, and it's a huge part of the puzzle. The ultimate definition of a well-controlled diabetic is a pet that has no clinical signs and does not experience hypoglycemia. The gold standard for assessing glycemic control and making informed insulin dose adjustments is the blood glucose curve. This involves measuring the pet's blood glucose every 2 to 4 hours over the course of an entire insulin dosing interval, typically 12 hours. The curve tells us 2 vital pieces of information: the lowest point the blood glucose reaches, known as the nadir, and the duration of the insulin's effect. The ideal nadir is somewhere between 80 and 150 milligrams per deciliter. If the nadir is too high, the insulin dose may need to be increased. But if it's too low, specifically below 80, the dose absolutely must be reduced to avoid dangerous hypoglycemia, no matter what the rest of the curve looks like. A common pitfall is the Somogyi phenomenon, or rebound hyperglycemia. This happens when an insulin dose is too high, causing the blood glucose to drop too low or too quickly. The body responds by releasing a flood of counterregulatory hormones like cortisol and epinephrine, which causes a rapid and dramatic spike in blood glucose. It can look like the insulin isn't working when in fact the dose is too high. The only way to spot this is with a glucose curve, and the treatment is always to decrease the insulin dose. Traditionally, glucose curves were done in the hospital, but this can be problematic, especially for cats who get stressed. Performing glucose curves at home is now strongly recommended. Owners can be taught to get a tiny drop of blood from the ear margin or another suitable spot using a veterinary-calibrated glucometer. It provides a much more accurate picture of what's happening in the pet's normal environment. Other monitoring tools have their place too. Urine glucose monitoring can be a helpful, low-stress way for owners to track control at home, though it's not very precise. A consistently negative urine glucose reading is a red flag that the insulin dose might be too high, warranting an actual blood glucose check. Fructosamine levels are useful for tracking long-term trends and for differentiating stress hyperglycemia from true diabetes, but they aren't sensitive enough for fine-tuning insulin doses. Ultimately, all these laboratory numbers must be interpreted in light of the most important indicator of all, the patient's clinical signs. If a pet is feeling great, maintaining a healthy weight, and not showing signs of excessive thirst or urination, their diabetes is likely well controlled, even if their glucose curve isn't perfectly flat. The tangled web of pancreatitis and diabetes. As we've hinted, The relationship between diabetes and pancreatitis is a particularly complex one. It's a classic chicken or the egg scenario. Does the pancreatitis cause the diabetes, or does the diabetes cause the pancreatitis? The evidence suggests that both can happen. The pancreas is an amazing organ with two distinct parts, the endocrine pancreas, which makes hormones like insulin, and the exocrine pancreas, which makes digestive enzymes. These two tissues are intimately intertwined. It's easy to imagine how severe inflammation in the exocrine tissue could lead to bystander damage to the fragile islets of Langerhans, destroying the beta cells and causing insulin-deficient diabetes. In dogs with chronic pancreatitis, studies have shown that a functional defect in insulin secretion can be present even before they become overtly diabetic, suggesting that the pancreatitis does indeed come first in many cases. However, the reverse can also be true. The metabolic state of diabetes itself, the hyperglycemia and often hyperlipidemia, can contribute to inflammation. Experimental studies in cats have shown that sustained hyperglycemia leads to an increase in inflammatory cells in the exocrine pancreas. And in human medicine, it's well established that patients with type 2 diabetes have a 2 to 3 times higher risk of developing chronic pancreatitis. This suggests that the diabetic state itself can predispose an individual to pancreatic inflammation. The most important clinical takeaway is that these two diseases frequently coexist, and it's vital to be aware of this. A diabetic patient with concurrent pancreatitis can be much more challenging to regulate. The inflammation causes insulin resistance, and as the pancreatitis flares up and subsides, the pet's insulin requirements can fluctuate dramatically, making them brittle diabetics. Recognizing and managing the underlying pancreatitis with supportive care and analgesia is a critical part of successfully managing the diabetes. When things go wrong, diabetic emergencies. While most diabetic pets can live long, happy lives with proper management, there are serious, life-threatening complications that can arise. The two most significant are diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic syndrome, HHS. Both are medical emergencies that require intensive hospital care. Diabetic ketoacidosis, or DKA, develops when there is a severe lack of insulin combined with an excess of counterregulatory hormones like glucagon. Without insulin, the body can't use glucose for energy, so it begins to break down fat at a very high rate. This process, called lipolysis, releases free fatty acids, which are then converted by the liver into acidic molecules called ketone bodies. When these ketones build up, they overwhelm the body's buffering systems, leading to a severe metabolic acidosis. This is the ketoacidosis part of DKA. The diagnosis of DKA is based on a triad of findings: hyperglycemia, ketonemia or ketones in the blood, and metabolic acidosis. Patients with DKA are typically very sick. They are often lethargic, vomiting, anorexic, and severely dehydrated due to the osmotic diuresis caused by both high glucose and ketones in the urine. Treatment is intensive and focuses on three main pillars: fluid therapy, electrolyte replacement, and insulin administration. The first step is aggressive fluid resuscitation to correct the profound dehydration and shock. Next is careful management of electrolytes. These patients lose massive amounts of potassium, but this can be masked initially by the acidosis, which shifts potassium out of cells. As soon as insulin therapy is started, potassium will shift back into the cells, and severe, life-threatening hypokalemia can occur if it's not supplemented aggressively from the start. Finally, a continuous intravenous infusion of regular insulin is started to stop the production of ketones and gradually lower the blood glucose. Hyperosmolar hyperglycemic syndrome, or HHS, is a less common but equally dangerous condition. In HHS, there is just enough insulin present to prevent the runaway fat breakdown and ketone production, but not enough to control the hyperglycemia. This leads to extremely high blood glucose levels, often over 600 milligrams per deciliter, and profound dehydration, resulting in a state of severe hyperosmolarity. These patients often present with severe neurologic signs due to the dehydration of brain cells. Management is similar to DKA, with a heavy emphasis on very careful and gradual fluid therapy to avoid rapid shifts in osmolarity that could lead to cerebral edema. Diabetes and the kidneys, a complicated relationship. Chronic high blood sugar can take a toll on many organs, and the kidneys are particularly vulnerable. In humans, diabetic kidney disease, or DKD, is the most common cause of end-stage renal failure. The pathophysiology is complex, but it starts with hyperglycemia. The high glucose levels cause the tiny filtering units of the kidney, the glomeruli, to work overtime in a state called hyperfiltration. This increased pressure and workload eventually lead to damage, scarring or glomerulosclerosis, and leakage of protein into the urine. Over time, this progresses to a decline in kidney function and chronic kidney disease. Systemic hypertension, which is common in diabetics, greatly accelerates this process. In our veterinary patients, the picture is a bit less clear. The same pathological mechanisms are undoubtedly at play. We see evidence of increased renovascular resistance and proteinuria in some diabetic dogs, for example. However, there is currently no strong clinical evidence of a consistent association between diabetes and the development of chronic kidney disease in dogs. It may be that dogs, who tend to be older when diagnosed, simply don't live long enough for the slow progression of DKD to become clinically apparent as atemic kidney disease. In cats, whose diabetes more closely resembles the human type 2 form, we might expect a stronger link. The evidence is mixed. Some large retrospective studies have failed to show an association, while a more recent study from referral hospitals did find that diabetic cats were significantly more likely to also have chronic kidney disease. Given the high prevalence of kidney disease in older cats in general, it's a relationship that warrants careful monitoring, even if the direct causal link isn't fully established. Navigating anesthesia in the diabetic patient. Finally, it's important to touch on what happens when a diabetic pet needs anesthesia for another procedure, whether it's a dental cleaning to treat insulin resistance-causing dental disease, or cataract surgery, a common consequence of diabetes in dogs. Managing these patients requires careful planning. Whenever possible, procedures for diabetic patients should be scheduled for first thing in the morning. This allows them to get back to their normal feeding and insulin schedule as quickly as possible and allows for close monitoring throughout the day. There's no single perfect protocol for preoperative insulin, but a common recommendation is to give 1/4 to 1/2 of the patient's usual morning dose of insulin. Giving the full dose without a full meal is risky, but withholding insulin completely can lead to significant hyperglycemia and ketoacidosis, especially with the stress of the procedure. They may be given a small meal in the morning before their insulin dose. Once under anesthesia, their blood glucose must be monitored frequently, typically every 30 to 60 minutes, so that dextrose or additional insulin can be given as needed to maintain a target blood glucose of around 150 to 250 milligrams per deciliter. Fortunately, there are no specific anesthetic drugs that are absolutely contraindicated in diabetic patients. The anesthetic protocol should be tailored to the individual, just as with any other patient. One small caveat is that alpha-2 agonists, a common class of sedatives, can cause a transient increase in blood glucose, so this needs to be kept in mind during monitoring. In conclusion, diabetes mellitus in dogs and cats is a multifaceted and manageable disease. From the insulin-deficient dog to the insulin-resistant cat, each patient presents a unique challenge and requires an individualized plan. Success hinges on a deep understanding of the underlying pathophysiology, a thoughtful and flexible treatment approach, diligent monitoring, and above all, a strong, communicative partnership with a dedicated pet owner. While the road can sometimes be bumpy, with careful management, our diabetic companions can continue to live full, happy, and well-regulated lives. Thank you for listening. The titles for the referenced papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.